Thank you very much. My name is Falk from Sydney, Australia, and my junior colleague was going to give this address. I did try to get a message to you, I'm sorry. Thank you all for listening to me, and I have no disclosures.
The small one? Like a radio?
Yeah. Green arrow.
And
Green arrow?
Is it working? Is it possible the green arrow here is not working in our machine? Here we go.
I'd like to talk to you about the pulmonary findings in repair of giant hiatus hernia. Giant hiatus hernia is a topic which I think probably includes types 2, 3 and 4 hiatus hernias. I note that there's many different synonyms that can be used for it. We find that these large hiatus hernias constitute part of our practice, but they're not a large part of our practice in doing upper GI surgery. But you'll note from this chest X-ray that the large hiatus hernia can certainly displace other organs in the chest, and this is not an unusual sort of picture as to what we see. They do cause potentially life-threatening complications, certainly in the symptomatic patient, and non-operative treatment certainly has an attached mortality to it. So as a surgeon, we like to fix these things. If at all possible, they tend to occur in elderly and quite sick patients. Laparoscopic repair, I think, has become a standard of care, and laparoscopic re-repair, we see in the last speaker, an extraordinary tour de force. I noticed during the course of many years of doing this surgery, and I'd like to thank my junior colleague for taking out some of the work which we in the unit have done, that a lot of these patients had shortness of breath. And this shortness of breath had a tendency to go away unpredictably in these patients after surgery. And this caused some bemusement, and I wish to look into it further. So in the literature, preoperative dysphagia, dyspnea in this patient group is recognised in more than 50% of patients. The cause for this shortness of breath is not known, and the resolution of the shortness of breath, the amount of resolution that one would see, is also not known. We wondered whether this was a respiratory origin which led to the simple difficulty with volumetric compression of the lung, and so we looked at this in a consecutive series of patients. During that period, we looked at 33 patients, and I will skip through this because I think time is short. They all underwent laparoscopic repair. There's a 2-year follow-up at least, and all the clinical usual approaches to this condition were stored in a database. They were evaluated in the usual sorts of fashion, and the only thing that we did particularly different with this consecutive patient group was to perform laboratory respiratory function tests pre- and post-operatively. The post-operative tests were planned for 3 months following surgery to allow recovery of the lung and the patient. At each clinic visit, the patient was assessed with a number of different scoring systems for dyspnea severity and also the GI QLI, quality of life. Briefly, the demographics of the group. We only ended up with 30 patients in the study, 2 excluded for incomplete data and 1 withdrew. This study was approved by the ethics committee of the hospital within which I work. There was a large defect in the diaphragm which we measured with a tape. The size of the stomach in the chest was measured either at barium meal, endoscopy or surgery, and you can see there the average percentage of stomach in the chest was in excess of 70%, so they weren't small hernias. Morbidity was 10%, one of which consisted of a nasty empyema. The others were food bolus obstruction. No mortality. Recurrence is the bane of one's existence. 4 asymptomatic recurrences on barium study, which we did routinely, and 1 larger symptomatic recurrence which hasn't required surgery as yet. Now you'll note that the symptoms in this patient group are quite extraordinary. I've run through them there: heartburn, chest pain, dysphagia, you'd all expect, regurgitation. But look at that, dyspnea, 87%. This does correspond with the only other paper that has been written on this subject from Seattle, Washington, 2002 by Lowe and Simchuk, who report 84%. And I note in the commentary regarding the paper, there are people who were somewhat taken aback by that. The results of the surgery of the respiratory function tests were interesting. 7 out of the 30 patients had respiratory disease primarily, had abnormal FEV1 on VC, and the rest were normal. However, we notice if you look there between the preoperative group and the postoperative group, that the FEV1 didn't change, the forced vital capacity didn't change, DLCO didn't change, nothing changed, nothing was significant. And yet, the patients got better. We found that 76% of them, I don't think I showed you that slide properly, did I?
Yes, you did.
Oh, I didn't demonstrate the post-operative, the post-operative scores of dyspnea. You'll find that dyspnea dropped so that we found that there was only 13% or 4 patients had continued dyspnea. I beg your pardon for that. We looked at the subgroups a little bit more completely. Patients with no dyspnea and a large hiatus hernia showed no improvement. Patients who had dyspnea improved and not completely gone also showed no difference. And of course the other group showed no difference. We couldn't find anything. So I would conclude from looking at our short consecutive case series, which is a small proportion of the large hiatus hernia series that we have, that symptomatic relief of dyspnea can be predicted in excess of 3/4 of the patients. There was really no objective change in respiratory function tests, but I draw your attention to Lowe and Simchuk's paper, which showed there was. The mechanisms of dyspnea would, I think, perhaps be a little bit more complex than simple respiratory function tests, and it could be cardiac in origin in some patients, or it could be minor segmental VQ abnormalities in others. We will look at the alternative mechanisms. Dyspnea has long been a contraindication to surgery in patients with hiatus hernia. I think in patients with giant hiatus hernia, it perhaps now should become an indication. Thank you very much.